are going to get started. We have two more talks. This is the home stretch. All of you guys have been really good, staying engaged. And I would like to invite Dr. Sridevi Juwadi, one of our past presidents, to introduce our next speaker, Dr. Roopa V. Dr. Juwadi.
Good afternoon, everyone. Thank you, Anup and Amit and CME team for putting up this fantastic program. It's been very helpful and informative. On the same lines, our next speaker is my dear friend, Dr. Roopa V. She's a gastroenterologist who completed her fellowship and has been faculty member at UT Southwestern since 2010. She is currently an associate professor and also is serving as medical director of digestive disease clinic at UT Southwestern Medical Center. Her clinical interests are colon cancer screening, irritable bowel syndrome, and small bowel diseases. She's going to give us an overview of gut health, important gastrointestinal cancers, screening, and lifestyle modification to prevent them. Thank you, Roopa, for being here. I know you're on call. You took a break and came. Thank you so much.
Thank you, Sridevi. Thank you for the intro. I truly appreciate the opportunity given by Texas Indo-Physician Society to talk about gut health and GI cancers, which is close to my heart. So, Hippocrates, considered the father of modern medicine, once said, all disease begins in the gut. He must have had a crystal ball because it is fascinating that this statement holds true even 2400 years later. So, pass through. Some of you may have known someone who has been affected by GI illnesses such as IBS, peptic ulcer disease, Crohn's disease, ulcerative colitis, fatty liver, gastric cancer, or colon cancer. So personally, in my family, my grandparents were very healthy other than the age-related benign issues such as osteoporosis, but there is diabetes and hypertension in my first-degree relatives. But cancer did hit close to home for my generation. I have two female first cousins who developed stage 4 lung cancer and bladder cancer by the age of 40, despite the absence of any family history of cancer. So that makes you take a pause and makes you think, how did the shift happen and why? And what is there in store for me, for my kids, and their kids? So my daughter, who'll turn 19 next month, she just had her physical. So I got her labs, obviously, as a mom, I was checking her labs, and I called her. I said, well, you need to work on certain things. And then she said, but mommy, I can deadlift 200 pounds, and my BMI is 21. I said, my dear, that does not equal to anything, So she basically heard half of this talk on the phone. So regarding the cancer prediction, it is estimated that by 2040, there will be 28.4 million new cases of cancer compared to 19.3 million in 2020. If you think about it, that is a 47% increase in cancer over 2 decades. It's a frightening statistic, right? Like in Sanskrit, there is a saying, Jatasya Maranam Dhruvam, right? Life is born and then the death is inevitable, but it all depends upon, do we have a choice in choosing how we want to die and what's lying for us. So the standard of living seems to play a role in the incidence of cancer, with the highest rate of increase, which is 95%, will happen in the underdeveloped countries that are transitioning to developing countries, compared to only 32% increase in cancer incidence in the countries that are already developed. So this is based upon the Human Development Index. So it seems like, unfortunately, that cancer seems to be the byproduct of modernization and increase in standards of living. So when you look at the worldwide incidence of cancer, prostate, lung, and colon cancer are the top 3 in men, and breast, cervical, and liver cancers in women. And when you look at the mortality, the lung, prostate, and liver are the common cancers of death in men, and with the breast, cervical, and lung cancer leading the pack in women. So what are the colon cancer trends in US population? So when you look at this graph, the incidence of colon cancer has decreased in US from ages 50 and above. So this may be because there is increased uptake of colon cancer screening programs and also removal of precursor lesions, which are tubular adenomas, through colonoscopy, and decreased smoking in the Western population and increased use of aspirin. But however, the trends in colon cancer incident in younger population, which is less than 50, have been on the rise. And if you look at the statistic, that incidence is almost equal to the ages 50-year-old in 1992 before the implementation of colon cancer prevention. And the median age of colon cancer has decreased from 72 to 66. So by 2030, it appears that there will be a 12% increase in colon cancer and 25% increase in rectal cancer in people who are younger. So talking about the colon cancer, it goes through the, as you all know, it goes through the adenoma and the precancerous polyp, which we call adenoma, then advanced adenoma, and early stage cancer. So this is driven by many mutations, like as indicated in the slide, and colon cancer is the second leading cause of cancer death in US. So when you look at the early onset of colon cancer in people who are less than 50, so you can think about what is the thing that is driving this cancer in them. Is it genetics or is it environmental factors? So it is actually, genes contribute only, the genetic factors such as Lynch and so forth, they contribute only 25% of cancer in people less than 50. So the majority of the cancer that's happening in younger population is due to environmental factors and sporadic cases. So based upon this, the US Preventive Task Force, they made a recommendation that they have decreased the colon cancer screening from age 50 to 45. So now, as we say, 45 is a new 50. And and the screening can go up to 75, and after 75, you make a decision after discussing with the patient, regarding the comorbid conditions and life expectancy and so forth. So, and there are several screening modalities that can be used to do the colon cancer screening. And these are recommended, which is, as you all know, yearly FIT test, and you can do the stool DNA test every 3 years and CT coronography every 5 years. And colon cancer, colonoscopy, it can be from anywhere from 1 year to 3 years to 5 years to or 10 years based upon their adenomas. So what are the benefits of doing colon cancer screening at age 45? Have we achieved anything, or what are we going to gain from this? So by decreasing the screening age from 50 to 45, the mean life years that are gained for 1,000 individuals is 26. And in simpler terms, by decreasing the age of screening to 45, you avert 3 cases of colon cancer when compared to starting the screening at age 50. So then I'm going to move on to what we call the non-alcoholic fatty liver disease, so which is also a global pandemic. And about 25% of world population has non-alcoholic fatty liver disease, and NAFLD is the hepatic manifestation of the metabolic syndrome. But there is something called a lean NAFLD and non-obese NAFLD, because if you think about NAFLD, the risk factors are obesity and diabetes and hypertension and so forth. But even in people who are not obese per the current BMI criteria, they can still have NAFLD. So there was a study that was published in Lancet in 2020 where they looked at the patients who had NAFLD, and among the NAFLD they looked at the BMI, and about 20% of those patients, of the subjects, where they actually had a lean BMI, so they were not fat at all. And then for 40% they were non-obese, so even though you're not obese you can still have NAFLD. And when they look at the general population, that looked at the NAFLD, about 5% of general population had a lean NAFLD, and 12% had non-obese NAFLD. And the interesting thing is that among the people who had lean and non-obese NAFLD, about 40% already had NASH, and 30% had fibrosis, and 3% already were at cirrhosis. So that's very concerning, when we think about it. And the Asian population is estimated to go by, I think, 36 million by 2060. And Asians are at the highest risk for having NAFLD and metabolic syndrome. So you can think how much of an epidemic it will be in this country. So when you look at the all-cause mortality per 1,000 patients per year, the all-cause mortality was 12.1 in people who had lean NAFLD and non-obese NAFLD. And also if you look at the cardiovascular mortality also was also high. So there are pathways, for risk stratification of NAFLD that can be implemented by the primary care, endocrinologists, gastroenterologists, obesity specialists, and also cardiologists. So the stage one includes, the step one includes how to identify the patients at the risk. Then you take their risk factors, which if they have 2 or more metabolic risk factors, and if they have type 2 diabetes, or if they have steatosis on any ultrasound. So that's another important thing to do. So once you identify the patients who are at high risk, then you take the history and also check for the transaminases and especially their alcohol intake. Then there are some non-invasive testing for fibrosis. So there are calculators that take into account the transaminases and also their lipoprotein levels, alpha lipoprotein A, the triglyceride and HDL levels, and there's a score that comes. So if the score is between 1 to 3, then they're at low risk. If the score is more than 1.3 to 2, then they're at intermediate risk. If they are at intermediate risk, then further testing can be done via sonography, to look at the liver stiffness. If the risk is high, then you obviously refer to a hepatologist. So how do you manage these patients with NAFLD, right? So the first thing is the lifestyle modifications and weight loss. And that is a cornerstone of therapy for NAFLD. So when you look at the Asian Americans, there is heterogeneity of obesity prevalence in Asian Americans in US. As you all know, or some of you may know, that in the BMI criteria for Asians is completely different from non-Asian Americans. So the BMI criteria for obesity for Asians is more than 25 and overweight is more than 23, whereas the criteria for the Caucasians is more than 25 and 30. So there was a nice study that was done by Dr. Shah, who was part of the Masala study, and that was published in Annals of Internal Medicine. So they looked into the various ethnicities among the Asian Americans. And if they applied the old criteria, the overall prevalence of obesity was 11%, but if they applied the new criteria, the overall prevalence of obesity was 22%. And you can see here, it's the same thing for every ethnicity, which is Filipinos, Japanese, Asian Indians, it was 22%. So this is another thing that we need to consider is that, Asian population have a different metabolic syndrome when compared to the non-Asian Americans, and then we need to have a strict diet and lifestyle management there. And this is the same thing that says, like in the Masala study, like if you have 3+ risk enhancing factors, which are mostly like high sensitive CRP or LDL cholesterol or high lipoprotein A, you have 2 times increased rate of the coronary calcium, and that leads to like adverse cardiovascular events. So I'm going to move on from the NAFLD to colon cancer. So this is what we call an exosome. So the biology of cancer is known to be heterogeneous, and this variability is one of the issues which contributes to alter the relationship between dietary factors and cancer risk. So diet is only one part of the exosome that has all the exposures experienced by an individual over his or her lifetime. This means that the mechanism involved in cancer is so dynamic and they're intertwined that analyzing their effect is complex, and that a cause and effect relationship between diet and cancer should be evaluated in the context of that individual's exosome. So, approximately about 50 to 60% of colon cancer in US are due to modifiable risk factors. These are heavy consumption of alcohol, overweight, obesity, not being active, high consumption of red and processed meat, and low consumption of dietary fiber, whole grains, and other helpful nutrients. So this is a schematic diagram that shows that the interplay between diet and gut microbiome and how do they affect the host metabolism and immunity. Diet contributes to about 40% of all cancers, and about 20% of cancers are the direct result of chronic inflammation. And modulating the gut microbiome with the help of the diet, it can regulate the gut physiology and change the host metabolism and the response to the host immunity. All right, so we're going to talk about gut microbiome. So there are some fun facts about gut microbiome. We have billions of microbiome in our gut, right? And if you want to be very objective, 1 gram of stool has about 100 billion bacteria. And it would take about 100,000 of today's highest capacity thumb drives, which is a terabyte, to store 1 teaspoon of stool bacterial DNA. So so sometimes, like we can say, well, I'm not fat. I'm fat because of my gut microbiome, because I have so much gut microbiome in my body. But what are the healthy bacteria? We always say the good bacteria and the bad bacteria. 2 things that you have to remember is a Bacteroides species and the Firmicutes species. So these are present in the healthy gut, and the unhealthy gut is dominated by the Proteobacteria, Actinobacter, and mainly the Fusobacteria. So what are the factors that shape the gut microbiota? Basically, mode of birth, whether it's vaginal or C-section, your genetics, early childhood exposure to antibiotics. In this country, on an average, the kids, they get about 2 to 3 courses of antibiotics by the time they turn, 5 or 6. Gender, diet, obviously age, as we age, things change, and gastrointestinal transit using medications such as antibiotics and proton pump inhibitors, and psychological stress, that plays an important role in altering the gut microbiome, as well as the environmental factors such as tobacco and alcohol. So this is a slide that explains what I have said before. What are the bacterial community that are more predominant if based upon the environmental factors? So if a person had a vaginal delivery versus a C-section, they will have the good bacteria such as the Lactobacillus, Prevotella, and the Bifidobacterium and Bacteroides. And also the breastfeeding versus formula feeding. There is no shaming up here, but this is the science, this is the facts up here. Breastfeeding increases the normal gut microbiome, which is the Bifidobacteria and the Lactobacillus. But the minute you introduce a solid food, the gut microbiome changes. So what are the effects of gut microbiota on the host physiology? The main important thing is the short chain fatty acids. So the short chain fatty acids, they are formed by fermentation of the dietary starches. So bacteria, they metabolize the dietary starches into short chain fatty acids. So short chain fatty acids can provide up to 600 calories, and they help maintain the colon health. So they are effective in maintaining the motility and the permeability, sensation, and also like immune activation. Another thing is the bile acids. So the bacteria, they deconjugate the bile acids, and they also do dehydroxylation. The excess bile acids, deconjugated bile acids, can adversely affect the gastrointestinal motility, permeability, and immune activation. And then the gases, which is the methane, hydrogen sulfide, and hydrogen gas. These 3 are the component of the bacterial component of the breath test we do for small intestinal bacterial overgrowth. And excess of methane, hydrogen sulfide, and hydrogen can lead to decreased gastrointestinal motility, stasis, and constipation. So then you can ask, well, what are prebiotics and probiotics? Like if our health is dependent on our gut microbiome, then what is the role of pre and probiotics? So basically prebiotics are something, they are live organisms that are beneficial to one's health. The probiotics, they modulate the cytokine profiles. They also induce tolerance to the food antigen. And there are some non-immunological benefits. They basically compete for food, and they compete for nutrients with the pathogens. They alter the local pH. They produce bacterocins to inhibit pathogens. They scavenge the superoxide radicals, which are involved in the chronic inflammation. They stimulate the mucin production, and so forth. So they also maintain the intestinal barrier function. Then what are prebiotics? So prebiotics are basically the food sources for the probiotics. They help in formation of the short chain fatty acids and absorption of the ions. So the prebiotics also maintain the gut immunity in the form of secreting the cytokines and increasing the levels of IgA. So the combination of the pre and the probiotics is called the symbiotics. So this is a slide that tells you the clinical use of pre and probiotics. So where can we use? There is some data of using the Saccharomyces boulardii and lactobacillus in antibiotic-associated diarrhea and the C. difficile-associated diarrhea. And the fecal microbial transplantation is one of the cornerstone for refractory C. diff. And we do have Rebiota, which is a feces that can be given through enema. And just recently, there's a pill that has been approved by FDA, which will come in a couple of months. So you take about 4 capsules for 3 days for refractory C. diff. And it is also used, the probiotics also used for chemoradiation-induced diarrhea. And for Crohn's disease, especially the VSL number 3, for pouchitis, you use VSL number 3 and VSL number 6. So these are the indications and clinical uses of pre and probiotics. So coming to the colon cancer, since the diet and the gut microbiome plays an important role in how in altering the host metabolism, and what is the role of the gut microbes in the risk of colon cancer. So this is a list of the gut microbes that are associated with higher risk of colon cancer, which is the Fusobacterium and the enterotoxigenic and also the E. coli. And the good bacteria are the bacteria that produces the short chain fatty acids, such as the Bifidobacterium and so forth. And what is the relationship between environmental factors, the gut microbiota, and the colon cancer? So the environmental factors, which are the risk factors, are obviously smoking, diet, obesity, and lack of activity. So this is the risk, this is a relative risk causing the colon cancer, and what are the associated microbes with it. In patients who are overweight and obese, in people who are overweight and obese, there is decreased Bacteroides and Firmicutes, which are the good bacteria. And this causes increased levels of lipopolysaccharide levels, and also the epigenetic changes in the colonic epithelial cells, and that can lead into colon cancer. And especially the diet, if you look at the Western diet, the relative risk of association with colon cancer is 1.4, and because it increases the bad bacteria, which is Bacteroides and E. coli. And if you look at the Mediterranean diet and also the fiber has a positive effect because the fiber increases the short chain fatty acids. So what is the role of obesity and red meat risk in colon cancer? So we all know, these are one of the modifiable risk factors for colon cancer. So basically what happens in the obesity, there is a preponderance of what we call the unhealthy bacteria, and they they basically drive the pro-inflammation in the gut, and also they can make epigenetic remodeling in the colonic epithelial cells, and secrete the inflammatory mediators such as the secondary bile acids. And that leads to decrease in the gut barrier function, and also changes in the gene expression and the DNA damage, and causing colon cancer. And how about red meat, right? So the heme iron, it basically it is a food source for the mucin degrading bacteria, and that can decrease the gut barrier function. And the processed meat have excess bile acids, so the anaerobic bacteria, they deconjugate them into secondary bile acids, and that increases the oxidative stress. And the sulfur reducing bacteria, they increase the hydrogen sulfide, so they increase the cell proliferation. All these things can lead into colon cancer. So when we talk about the omega-3s and fiber that decrease the risk of colon cancer, how do they do that? So basically the omega-3s, they alter the production of the microbial regulators, and they put selective pressure due to the altered gut environment. They basically alter the gut microbiome, and that decreases the risk of colon cancer. And fiber, everybody, so the standard recommendation is that we have to have about minimum 30 grams of fiber a day. So if you eat a cup of raspberries and a cup of quinoa and a cup of cooked green beans, you get about 28 grams of protein, 28 grams of fiber a day. So that's enough. So it's not like, like you have to eat a lot of salads or something like that. You can choose the fiber very selectively, because there are a lot of high fiber foods. So how does the fiber help decrease the risk of colon cancer? Because the fiber is the food source for gut bacteria, and again the short chain fatty acids, they come into the scene. They basically decrease inflammation, they increase the homeostasis of the gut, and it decreases the colon cancer. So this is a slide that's showing the interactions between the diet and the gut microbiome. So basically, like if you eat the Western diet, how would that change your gut microbiome? What type of bacteria would your gut have now? And how does that affect, what type of effect that it has on your physiology, and then what does it lead to? So basically the Western diet is known to be implicated in obesity, colon cancer, and type 2 diabetes, because they do have increased bacteroides and increased enterobacter. And if you look at the Mediterranean diet, all of a sudden, the good bacteria that we call the bifidobacteria, the lactobacillus, and the fusobacterium, they increase in number, because they increase the short chain fatty acids, and that increases the risk of cardiovascular disease and obesity. The same thing with the plant protein, right? The plant protein is beneficial because it increases the short chain fatty acids, but the animal protein, it has the opposite effect. It reduces the short chain fatty acids, and animal protein has been kind of implicated in kind of increased incidence for inflammatory bowel disease. So how about fats? The saturated fats and the unsaturated fats, right? So the saturated fats, they cause increase in bacteroids and lead to obesity and cardiovascular disease and diabetes. However, the dietary fiber, again, anti-inflammatory effects and decreases the risk of obesity, colon cancer. So this is a kind of a slide that explains everything, how do the diet and environmental factors impact the intestinal microbiomes, and how do they influence the colorectal carcinogenesis? Basically, what does the obesity does? What does activity does? What does high fiber intake? And if you eat a lot of red meat, how does what happens at the cellular level? And if you have a lot of bile acid production, what does that happen? So, as I said in the previous slide, it said like the diet contributes to 40% of all cancers, right? So we have lots of diets available there, tons of them, and each diet, it comes with its own rules and regulations, what to eat, what not to eat. And this is only a short list of it. We have the ultra-processed food, the FODMAP diet, which is used in irritable bowel syndrome, and then we have the gluten-free diet that is used in celiac disease, the lactose-free diet, and we have the Mediterranean diet that has been shown recently again and again that it has a very positive effect on the cardiovascular health, the irritable bowel. So I'm going to briefly talk about the ultra-processed foods, because we are surrounded by ultra-processed food. The cakes, the chocolates. I mean, I'm guilty as charged too, but it's hard not to succumb to the pressure, right? So what does the ultra-processed food do? So basically the ultra-processed food, again, they have been, this is a study that showed that eating ultra-processed food has increased the risk of Crohn's disease. It has not increased any risk in ulcerative colitis, but it does increase the risk of Crohn's disease. And there are a subtype of ultra-processed foods that have significantly showed an increased risk of Crohn's disease. Basically, the one that have a lot of salt in it, artificial sweeteners, the stuff that they use in icing, which is basically the titanium oxide and the aluminum. The animal studies have shown that the rats, they do develop colitis on that. And the emulsifiers and the thickeners, that are used in ultra-processed food, they promote intestinal inflammation. So we're going to talk about the Mediterranean diet briefly, and what is its effect on the gut microbiome composition, and how does it change the gastrointestinal activity. So basically the Mediterranean diet, what it does is that it alters the gut microbiome, and it also decreases the gut inflammation. So for example, is the gut microbiome related to your genetics, or is it acquired? So this is a study that they looked into that. Basically they took all the relatives, from the same gene pool, and they looked at the different dietary patterns. So it's not the genes, it's not the genetics that drive your gut microbiome and so forth, your risk for the cardiovascular disease. I mean, when I say it's not your genetics, it's not entirely your genetics. Because in these people, eating a certain type of Mediterranean diet has shown to have a different type of microbiome, like a favorable microbiome. But people who were not eating Mediterranean diet, even though they share kind of same gene pool, they had a different type of microbiome. So we talk so much about the Mediterranean diet. What does it involve, right? So basically it is rich in olive oil, fruits, vegetables, whole grains, fish, legumes, seeds and nuts. They also add a little bit of alcohol too to that. So basically the components of the Mediterranean diet, they have antioxidant effect. They decrease the cholesterol synthesis in the liver. They decrease the cholesterol absorption in the intestines. They also decrease the resistance, like insulin resistance we see in diabetes and NAFLD. So what are the exact components of Mediterranean diet? What are the elements and what effect do they have on cancer and cancer risk? So the fruits and vegetables, as you know, it is rich in antioxidants and micronutrients. They have anti-tumorigenic effect, and that leads to a less risk of breast cancer, urinary tract cancer, and GI cancers. The fish, which are rich in long-chain omega-3s, they decrease the tumor cell growth, leading to decreased risk of colon cancer and liver cancer. Olive oil, which is rich in the polyunsaturated fatty acids, it has a chemoprotective effect, and thus by can decrease the risk of breast cancer, ovarian cancer, and colorectal cancer. What does the meat do? The meat is rich in heme, and it promotes tumorigenesis. And we know eating red meat and processed food, there is increases for colon cancer, lung cancer, especially pancreatic cancer. The keto diet, which is a high fat and low carbohydrate diet, it is proven that there is increased risk for pancreatic cancer with the keto diet. And what do whole grains do? They are rich in selenium, copper, and vitamin E, and they also act as anti-carcinogenic properties. They have antioxidative activity, so they decrease the risk of colon cancer and stomach cancer and breast cancer, and also red wine. So the resveratrol and the quercetin that is in the red wine, there is kind of a controversial thing that it actually helps or not, but that is part of the Mediterranean diet, and they say you can have the red wine in moderation. So what is a Mediterranean diet? It's basically a lifestyle. It's not sticking to a certain type of diet. It is basically eating 2 to 3 servings of fruit and vegetables and legumes that are grown locally, and at least 2 servings of dairy products and 5 to 6 servings of fish, like for the omega-3s and poultry, and 3 servings of egg. And as the pyramid goes onto the top, the red meat is as less as possible. So again, going back to the Hippocrates, he said, let food be thy medicine and medicine be thy food. Reportedly, he said that. But I would say, there's a saying that says, you are what you eat. But I think I can extend that by saying, you are what your gut microbiome is. So I think I have given enough information for you guys to kind of think about, how you're going to plan your breakfast, lunch, and dinner. Thank you.
Thank you very much, Dr. Vemulapalli. I guess there are no questions. Thank you again. Any questions? Well, I guess there's no. I guess there's no. Any questions? Okay, go ahead.
Yes, Swati?
I have a question about infants born by a cesarean section and who have not been exposed to breastfeeding. Is there any way of altering or enhancing their gut microbiota?
Good question. So the question goes to, can we give any supplemental probiotics to the infants, who were born by C-section and not been exposed to the breast milk? There hasn't, intuitively, it thinks like it is reasonable to do it, but, there are not much any studies, that said that you have to supplement for sure. To be clear, there are not many studies, to kind of support that.
So you mentioned prebiotic and probiotics, and if you go on Google, Amazon, anywhere, you will find like thousands of products. Any specific prebiotic or probiotic brand or anything specifications that somebody can take that will be helpful? And the second question is, you said Mediterranean diet includes fish. What about people who are vegan or vegetarian? What can you substitute that with?
I think it is just the omega-3s that you can probably substitute with omega-3s, that are commercially available. Nuts and seeds also you can do that. So to your first question, what are the available probiotics? So the probiotic industry is a billion-dollar industry. And so any probiotic that you want to look for has to have like several strains of lactobacillus and also bifidobacterium and Saccharomyces boulardii. So the ones that are commercially available are like Align, that has mostly bifidobacterium, so we use it for like abdominal bloating and constipation. And for the diarrhea, we use Cultural, so that has lactobacillus species. But there are so many other food products too, like the Chobani. The Chobani has a probiotic yogurt that's very good. So no need to spend so much money on the probiotic pills, like unless you're lactose intolerant. Like you can still kind of get your probiotics through the dairy products.
Thank you very much, Dr. Vimalapalli. Round of applause.